Good afternoon. Thanks for coming this afternoon. Today we'll be talking about patient counseling and strategies to improve the patient experience. As you know, our institution is focused on patient safety, and we are focused on due north. So our patients are at the center of everything that we do, and we will be talking about motivational interviewing and teach back to help ensure the safest transitions for our patients. Okay, we're going to have a little skit um, to show us an example of perhaps not the best patient interaction.
Good afternoon.
Hi, I'm here to pick up my prescription.
Okay, what's your name?
Jane Smith.
What was that?
Jane Smith.
Okay, hold on 1 second. Here you go, Miss Smith. I've got a medicine here for you.
Oh, is it going to make me feel better? What is this?
It's an antibiotic.
I've
do-
been on a lot of antibiotics.
Do you know why you have this one?
Well, I have an infection.
Yeah, that's exactly right. You're just going to take it twice a day for a few days.
Does it interact with any medicine?
What other meds are you taking?
Well, I don't know. I have a blood pressure medicine.
No, that's fine.
I have something for heartburn,
No, that's fine too.
so I can take it any time of day.
Yeah, you need to take it twice a day. So you try to do it in the morning and the evening time then.
Okay.
Okay? And take it for, I think it's for 3 days. So just take it for the 3 days and you should be feeling better.
I'm worried it's not going to work.
Well, I'm sure it'll be fine. Your doctor saw you earlier today. I'm sure they were looking at everything and wanted this to be you to take this one.
All right, but if I'm back here in a week.
Well, hopefully this will take the trick, okay?
Okay.
All right, have a good one.
Okay, so first we'll look at Merriam-Webster's dictionary for communication and counseling. So communication is the act or process of using words, sounds, signs, or behaviors to express or exchange information or to express ideas, thoughts, feelings to someone else. Counseling, however, is the advice and support that we give to people to help them deal with problems and make important decisions. There are universal communication principles, and those are that everyone benefits from clear information. And many patients are at a risk of misunderstanding their information, and it's very difficult for us as providers to identify those patients. Testing in general for reading levels does not ensure patient understanding in the clinical setting. You've probably heard of a RAT test or a RIM test. Both of these are tests that will help to identify reading levels. It starts with very simple words and then moves forward to more difficult words, perhaps like constipation. There's also a test called TOEFL, and in that particular test, it's a better test for understanding, but still, none of these tests have been shown to clarify understanding for patients. Communication. So George Bernard Shaw was an Irish playwright, and you may be familiar with the 1941 play Pygmalion, which actually came out later as My Fair Lady. And so he says it right. The problem with communication is the illusion that has occurred. We can also look at Edgar Dale's Cone of Understanding. Edgar Dale was a psychologist, and he also was at Ohio State University and did a lot with audiovisual techniques. And this is probably his most famous source that he has given us. And so it's not surprising to see, and you probably have heard most of this, that we only remember 10% of what we read. And this is after 2 weeks. But also, if we do dramatic presentations or we simulate real-life experiences, then we may remember 90% of what we say and do. We have several objectives today. List the barriers to learning and communicating, describe the examples of sensory barriers, define teach back, and identify the materials for teaching or other clinical communication needs. We'd like for you to be able to demonstrate where documentation of patient and family understanding of education occurs at our institution, state the stages of change, and being able to summarize motivational interviewing. Also, you should be able to compare and contrast the current and ideal state of medication counseling at UVA. So here's a great example. take with meals. The patient says no problem. So what does that mean? Does that mean I only eat once a day? I should take the medicine once a day. Or as you see in this comic strip, I eat all the time, so maybe I should take it 8 times a day. What are the barriers for learning and communication? You can see these listed here. These are all factors that can influence the learner's ability to acquire and apply education and information regardless of their education level. I can tell you, you may have had this experience in the hospital, in the outpatient pharmacy, or in clinics, that we have some of the brightest individuals that we are talking to about medication or their disease state. And it's totally different. Their ability to understand and appreciate that is influenced by health literacy, which we'll talk about later. So factors that contribute to misunderstanding, they're provider factors. When you look at this list, which one do you think is the most prevalent? Probably limited time. We all have limited time. So limited time for discussion, difficulty in simplifying complex or confusing medical terms, having to communicate a lot of information at once. And as pharmacists, we're really good at that. I mean, we can say a lot in a little bit of time. And then also overestimating the patient's ability to understand the information. And then there are patient factors as well. So a lack of understanding of medical terms or jargon, if they have an older age, possibly cognitive decline, language barriers, feeling overwhelmed by information and emotion. We all know that perhaps not the best time to give information to a patient is when they're at their sickest. The ability to learn and comprehend and understand is difficult during those times. Medication that would affect memory or cognition. So some different examples here, and I won't go through all of these, but for cognitive memory loss, education and literacy, the ability to read or understand. And so I know perhaps in our clinic, in our UMA clinic, internal medicine clinic, our illiteracy rate is about 25%, which is twice the national average. So we serve a lot of that population here at the University of Virginia. Emotional issues, so anxiety or stress, and then again, language or cultural aspects, and not just language barriers, but what different terms mean to each individual. Physical, again, if the patient is in pain or they're fatigued or they have some kind of debilitation, it makes it more difficult. Then sensory, poor hearing or vision. So we're going to talk a little bit about TeachBack and go through the different questions that I have posed here. What is it? Who should I use it with? When should I use it? Where should I use it? Why should I use it? And how should I use it? So I want to define TeachBack is evidence-based. It's also called the Show Me method and is used to verify that a patient or family member understands what is being explained to them. If there is understanding, then the patient should be able to teach back what the information is accurately. Asking patients to repeat in their own words what they need to know or do in a non-shaming way. Often patients feel bad. You're talking to them, giving them a lot of information. It may be difficult for them to say, I don't understand what you're saying. Remember, it's not a test of the patient, but it's how well you explained a concept to them. And it's also a chance to check for understanding, and if necessary, reteach that information. Only 12% of adults in general have proficient health literacy. Almost 9 out of 10 adults lack the skills needed to manage their health to prevent disease. Patients frequently leave the healthcare setting without understanding what they need or being able to follow recommendations. So we should use TeachBack with all of our patients. It's critical for us to confirm understanding through TeachBack. And again, those at risk, which we've spoken about before, elderly, minorities, limited education, and people with chronic diseases. The TeachBack technique should replace the more common "do you understand?" And experience shows that patients will answer yes or nod their heads to such questions when they absolutely understand nothing. We see this often in clinic. Perhaps one of us has seen a patient, we've gone through some education, we've even asked them to do TeachBack, and they have some understanding, or they'll tell the doctor that they understand, and one of us will walk in the room and they have no idea what was just said. So it can be used in all clinical settings, and I just have a few examples here. As you know, we are doing teaching in our outpatient pharmacies, teaching in our clinics, teaching in the hospital, our meds to bed program. So we have a lot of different touches for patients and multiple opportunities to help them to understand their medications and their disease states. So Teachback provides that opportunity to check the understanding. We're going to rephrase it if the patient really is not understanding or not able to repeat the information back accurately. We're going to ask that patient to repeat the information until we're comfortable that they understand what we're saying. If they don't understand, that's when we may use other options, pictures, videos, apps on phones, etc. There's several different factors that contribute to misunderstanding. And I think that this is something that we've talked about previously. So here's a great example, discharge instructions. I don't know if anybody would like to attempt to read this. This could be what the patient actually hears, or also a patient that's not able to read well, what they're actually seeing. So this is what it says. Your physician has recommended that you have a colonoscopy. Colonoscopy is a test for your colon cancer, etc. So you can see this may be the information that's given to the patient or what we are verbally saying to the patient, and the prior slide shows how they have interpreted that. So how do we use Teachback? We want to be caring. We want to have a caring tone of voice. We want to have approachable body language. We want to slow down and pause. Pausing is really a great thing. It's difficult sometimes, especially I think as pharmacists, because we have a lot of information and we want to get that to the patient. But if we're pausing, we're giving them the opportunity to digest some of the information and then be able to ask questions. We want to ask, what questions do you have, not do you have any questions? And we want to ask how they learn best. I mean, some patients will say right off, I'm not really able to read, or I do better with pictures, etc. We may have them talk to, or for us, we may talk to a support person. They may have a family member or a care provider that can help them, identifying somebody at home. We always want to use an interpreter for language barrier patients and any person that is a limited English speaker. So we definitely want to do that, and we want to document that appropriately. So show and tell. We want to ask patients to demonstrate understanding. And this is a great example. So we know that inhaler technique is difficult. It takes a lot of hand, eye, and lung coordination. And some of the things that we can do is say, how would you tell your spouse about this? Or if you have a care provider, when you get home, how would you explain this to them? And we tell the patient we want them to do this because we do this so often, and we want to make sure that we understand that they're understanding what we have told them. So we may say, show me what you would do. We can chunk and check. We can summarize and check for understanding throughout. And we don't want to wait until the end, because often it's too much information at one time. And again, we would never want to ask, do you understand? So I have some examples of plain language. So things that we take for granted, and I think this is a difficult thing for us to do at times. And so instead of hypertension, we might say high blood pressure. Even ambulate, we would say walk. Optimal, many patients don't know what that means. We would say the best way. Negative, say that that's a good or a bad result for negative or positive. Even the term diet means different things to different people, and we might term that what you eat. Opportunity, that's a word that we like to use, but it's better stated as chance. So how do you find materials for teaching or other clinical communication needs? We can look at our patient education repository, Micromedics Care Notes. Our library has resources, and that's at uvahealth.com. We also should consider a referral to our patient and family library, which is located in the main lobby, and also encourage our patients to sign up for MyChart. So we're going to spend a little bit of time talking about motivational interviewing. And if you look at this particular comic, he's saying, you don't say much, but I've been told it's the therapeutic relationship that counts. A lot of motivational interviewing has to do with empathy, listening, and reflection. So Miller and Rolnick's definition of motivational interviewing is, as you see, collaborative. It's a style of communication, a language of change, personal motivation for and commitment to a specific goal by eliciting and exploring a person's own reasons for change within an atmosphere of acceptance and compassion. So Stephen Rolnick was a clinical psychologist, and William Miller was a professor and also a psychologist. And they joined together in the early 80s and developed, from other work, motivational interviewing. They printed their first book in 1991, and they currently have their third edition out. Originally, this was based on alcohol dependence, but it can be used for anything. So one of the contributors for motivational interviewing that Miller and Rolnick used was Carl Rogers. So he was a non-directive, client-centered psychotherapist. He lived from 1902 to 1987, and so he was looking at the client-centered approach, and this is where that came from. So the hypotheses and conclusions that are proposed by Miller and Rolnick that these are replicated findings. It's not just by chance. So small to medium effect sizes across the variety of behavioral outcomes. There's substantial effects on patient outcomes based on relationships with and characteristics of the provider. Again, empathy is the key construct of motivational interviewing, and it's been found to promote positive outcomes. Motivational interviewing is intended to influence patient factors that are associated with positive outcomes: hope, self-efficacy, and active engagement. Motivational interviewing may benefit from the contrast effect. It could be that patients have only experienced a more direct and confrontational approach, and they find that motivational interviewing is relieving. There's also cultural differences. More substantial effect sizes are with minority patients as opposed to the white population. So before we continue on, we need to understand the stages of change. So Prochaska and DiClementes had developed the trans-theoretical model of change, and you may be familiar with that, again, in relationship to alcohol addiction or addiction. So there's the stages of change: pre-contemplation, contemplation, preparation, action, and maintenance. And we understand that you can relapse at any given time following extensive periods of abstinence or at any given time in this stage of change. So pre-contemplation stage of change is when the person is unaware there is a problem or underaware of the consequences of that particular problem. An example is, I'm here because they made me come. It's their problem, not mine. This is also called external locus of control, and so it's when patients or clients or people feel like everyone else is responsible, not themselves. And then there's contemplation stage of change. It's a beginning awareness and an early understanding that there is a problem, yet it's uncertain of what they're going to do with that or if they fully understand the nature of the problem. An example would be, I know I lost control again and did things that I regret, but I only go overboard with the drinking because she makes me angry. Ambivalence, that's the hallmark of contemplation stage of change. That's the yeah, but stage, if you will. So it's common to hear two kinds of talks mixed together. Change talk, it's the person's own statements that favor change, self-motivating statements. And then there's sustained talk, the opposite of change talk, the person's own arguments for not changing, for maintaining the status quo. And sometimes that's in the same sentence. I want to quit smoking, But every time I've tried, I've gained weight, then I start again. I know it's bad for my health, yet I can't imagine not smoking. So I'm gonna read just a few examples, and I want you to think about if you think that this is sustained talk or change talk. But I love chocolate. So perhaps that's sustained talk, right? Well, I wouldn't mind cutting down on the stress in my life. Perhaps that's change. This person is thinking about that. I really hate pricking my finger to check my blood sugar. Perhaps that is a sustained talk. But these are opportunities for us to readdress and talk to the patient, maybe about an alternative site testing. How about, but I have to exercise? So that could be either way. Exercise is a good thing, I'm thinking about changing, or exercise to the point of injury. I'm doing too much of that. So when we're responding to change talk, there's something called ORS. Basically, when you hear it, respond to it. So we have open-ended questions. You want to ask for more detail or examples from the patient. You want to affirm or comment positively on what the patient is saying. And you want to reflect, simple or complex, just continuing what the patient is saying, and then summarizing what the patient has said, but also including the change talk in that summary. The writing reflects the natural and instinctive response of trained care providers is to fix the problem, make it right, use my knowledge and my training to tell you what to do. And this is what we often see with providers and pharmacists as well. We know it's right. We know what you should do. If you keep doing this, you're going to die. If you keep doing this, you're going to lose your eyesight. It's not very effective. What happens when these two meet? So the provider operating from the writing reflex says to the patient, you need to stop. The patient says, tell me something I don't already know. You haven't been compliant with the treatment plan. I've tried numerous times and I can't seem to stick with it. You have to take this to get better. You sound like my husband or wife or boyfriend or girlfriend. So the preparation stage of change is when the person has a good understanding of the nature of the problem. They can express the desires, reasons, and abilities and needs for change, and they can discuss making or considering plans to change. However, some sustained talk remains. An example, I know I need to manage what I eat and exercise to help control my diabetes, yet every other time I've tried, I've just gone right back to the same old, same old. I just don't know if I have what it takes to go the long haul. The action plan, that's when the client or the patient is actively taking steps to change but has not yet reached a stable state. I've been testing my glucose levels and I'm keeping track of what I've been doing. Yay, I quit smoking. I started exercise boot camp last week. And then there's the maintenance phase. That's when the patient has achieved initial goals, such as abstinence, and is now working to maintain gains. I have so much more energy now that I'm thinking of joining the YMCA and taking additional exercise classes. The spirit of motivational interviewing includes partnership, compassion, acceptance, and evocation. Partnership. So it's dancing as opposed to wrestling. Rolling with the resistance. Acceptance. So it honors each person's absolute worth, potential as a human being, and recognizes and supports the person's irrevocable autonomy to choose his or her own way. And we seek through accurate empathy to understand, which affirms the person's strengths and efforts. Compassion, to actively promote the other's welfare by giving priority to their individual needs. Evocation. People already have this within themselves. Much of what is needed is for us, and it's our task to help evoke it. It's a strength-focused premise rather than a deficit-focused model. Many of you in the room did the leadership training, and that's one of the things that we focused on, is that most of our lives we're always trying to develop the things that we don't do well, whereas we really should be focusing more on the positive things that we do and continue to do those well. So we have a patient case. This is a real case, a patient in our internal medicine clinic, but is also seen in the renal clinic. So EJ is a 54-year-old female seen in the discharge clinic, post-hospitalization for a hypertensive emergency. She has a past medical history of diastolic heart failure, end-stage renal disease, and she's on hemodialysis Thursdays and Saturdays. Hypertension, aortic stenosis, and end-stage and pulmonary hypertension. And she notes that we note that there's been a medication non-compliance through gaps in her refill history. So the patient refers to her medications as a blue pill or a pink pill. So we can help to create for her a meaningful list of medications, including pictures to help her identify her medications. We use the teach back approach. Show me how you will take your medicines for your blood pressure. Not how do you take them, but show me. It's been shown in studies that if we have patients actually show us in their hand the number of pills, and a good example is warfarin or blood thinner. So they may be taking 2.5 tablets or 3 tablets or 1.25. I just said that for some people in the audience. We want them to actually show us so that we have a clear understanding of what they're doing, because 2.5 might mean 2.5 milligrams. So we want to actually be able to visualize that. How many times a day do you take this medicine? And why is this medication important? So the patient is not on the transplant list due to her frequent emergency room visits and uncontrolled blood pressure. So part of what the pharmacist did was to try to find out what would motivate this patient to take her medicines. And questions that were asked: what makes it difficult to remember to take your medication every day? How do you feel when you take your medication? How do you feel when your blood pressure is high? The patient identified staying out of the hospital as a personal goal, and she felt positive encouragement from her renal and internal medicine teams and felt she could take better care of herself with this support. She appreciated working with our pharmacist, who's in the renal clinic, and our pharmacist in the internal medicine clinic to simplify and de-escalate her medication regimen. She was seen by her primary care physician and pharmacist in the discharge clinic on July 14th. She was seen every week by a pharmacist and received a weekly pill box fill and counseling. During the period from July 14th through August 25th, there were no ER visits, and that's during the time that the patient was receiving the pill box fills. She was not able to get a pill box fill at the end of August because she was out of town and was readmitted on September for elevated blood pressure. So this just shows us the importance of seeing that patient on a regular basis, helping her with her medications and her understanding and filling her pill box to avoid a readmission. So this is an example of a medication list that our renal pharmacist put together. As you can see, it has the directions. This is a patient that could read, and images of those pills. We'll speak just a little bit about health literacy. I have another comic strip here, and I'll read that to you. So there's the physician. It says, "Can I please talk to Pig?" This is Pig. "This is Pig. Hi, Pig. I have your test results." "Oh my goodness, what are they?" The physician says, "They're negative." "Oh God, no. How much do I have left? How much time do I have left?" "Relax, Pig. It's a positive thing." "Negative is positive?" "Yes." Then what's a positive result?" "A negative thing." "Positive is negative?" "Yes." "Are you sure?" "I'm positive." "Oh God, no. How much time do I have left?" So the physician says to the nurse, "Next time you call him." And the pig is saying, "You lived a good life, Doc." So you can see how easily just those terms positive and negative and giving results was very confusing. So what is health literacy? It's the ability to obtain, read, and understand and use medical information to make appropriate decisions and follow instructions for treatment. Why do we talk about this? Jeffrey, when he comes forward, he's going to talk to you more about language deficient patients or low English patients, limited English proficiency patients. So these are federal mandates. It's by Joint Commission. The Agency for Healthcare Research and Quality 2012 brought this forward again. It actually stems from a law in 2001 that says that all federal agencies, all CMS, must treat each person, each individual the same, and it is our due diligence to help those patients understand and give them the information in the language that they understand the best. Health literacy is more than a measurement of reading skills. It also includes writing, listening, speaking, cultural, and conceptual knowledge. 98% of medical errors are communication related. Healthy People 2010 and 2020. Everyone has the right to health information that helps them make informed decisions, and health services should be delivered in ways that are understandable and beneficial to health, longevity, and quality of life. This slide shows you the top 10 languages at UVA. The difference in 2014 and 2016, Spanish is still our top language, but you'll see that we have Arabic, Nepali, and Farsi that are in some, and also Dari is some of our top languages. The Charlottesville area is an area where we take refugees in, and so there are more and more of these patients here that we're seeing at UVA. I have a list of tools and resources here. Again, always want to use TeachBack to confirm that the patient or the family member understands the information given. As far as patient safety is concerned, with low health literacy, 40 to 80% of medical information that patients receive is forgotten immediately, and nearly half of the retained information is incorrect. Already mentioned that 98% of the medical errors are communication related, and that nearly half of all adult Americans, 90 million people, have difficulty understanding and using health information. I'm sure you're familiar with HCAHPS. I have it listed here, the acronym, but it's a standardized survey instrument and data collection tool to measure patients' perspective of hospital care. It's administered randomly to patients continuously throughout the year, and it reports out, the CMS reports this out 4 times a year. So different topics, 32 questions, and if we look in particular, I mean, we have an impact on pain management, communication about medications, and also discharge information. So we are impacting all of the patients that are here at the University of Virginia. It's time for our skit.
Good afternoon.
Hello.
What can I do for you today?
I'm picking up a prescription
Okay,
for Jane Smith.
Perfect. All right, let me get that for you, Miss Smith. All right, Miss Smith, I've got your medication right here. Do you have a few minutes I can go over some details about the medication?
Sure.
Perfect. So I've got an antibiotic here. It's called ciprofloxacin, 250 milligrams. You're going to take 1 tablet twice a day for 3 days. Okay. Did your doctor tell you anything about the medication?
He said it would help me feel better.
Okay.
I have to go to the bathroom. It's
Okay.
uncomfortable.
Can you tell me any other information the doctor may have told you to look out for with the medication?
He didn't really say much about it. He just said to finish the whole course.
Okay, that's right. That's really important that we take the entire course of the antibiotics. It's also important you want to take one of the pills in the morning and then 1 pill in the evening time, and try to space them out about 12 hours apart the best you can.
Okay.
And I also see on here that it looks like you were taking a vitamin, some calcium before as well too. Are you still taking those?
I am, for my bones.
Yeah, so it's also important that you try to space those out by a few hours. You don't want to take the antibiotic at the same time as those supplements and the calcium.
Okay.
Do you think that's okay? Will you be able to do that, you think?
Yeah, so can I take my calcium later in the afternoon?
Yeah, that would be
Okay.
perfect. That would be
Okay.
perfect, okay.
Okay.
So just to make sure that we got everything, can you tell me a little bit again about how you're going to take the medication?
So it's the ciprofloxacin, and I'm going to take 1 in the morning, 1 in the evening, 12 hours apart.
Okay.
And I'm not going to take the calcium at the same time.
Okay. And can you tell me how many days you're going to take it for?
3 days.
Perfect, okay. And then last but not least, do you have any other questions, or what other questions can I answer for you today about the antibiotic?
Is there any other interactions with any of my medicines?
I think you're good with the rest of the medications that we've got on your profile, so you should be good with those.
Okay.
All right. Well, I hope you feel better, and let us know if you need anything. Okay.
Thank you so much.
Bye bye.
Okay, so in just a second, Jeffrey Tingen is going to come forward and do the remainder part of this presentation. But I just wanted to summarize a couple of things. And so, you know, as pharmacists, we worry about the amount of time that we have. We're busy, involved in patient care. And just as a reminder, I mean, if we ask the questions, how do you take your medicine? How many times a day? Why is it important to take your medication to help to help elicit whether they understand what their medicine's for? There have been studies that have looked at this, and the time can take 3 to 20 minutes depending on the number of medications that the patient has had. Motivational interviewing, Teachback has shown to improve by as much as 80% patient understanding and adherence with medications and decrease hospital readmissions because there's additional understanding about medications. I want to leave you with this thought too. Many of you may know Rita Shane from Cedars-Sinai, and so she has instituted universal precautions. When we think about universal precautions, we think about blood pathogens, and we should treat every specimen as it's contaminated. And what she is doing is looking at medications, and we should treat every medication list, even in the electronic medical record, as contaminated or erroneous. And so it's our job as pharmacists to complete medication reconciliation and to make sure that there's a complete medication history, and also ensure that our patients and their caregivers have a treatment plan when they leave the hospital or they are transitioning from one place to another with an appropriate and correct med list. Okay, with that, Jeffrey, thank you.
Good afternoon. So I'm now going to spend the rest of the presentation today discussing a little bit about the current state of medication counseling provided by UVA pharmacists right now. So initially, as of December 2016, currently this is some examples of the medication counseling currently being performed by UVA pharmacists in different settings. So in our outpatient pharmacies, and we have many of those, currently that counseling is being provided to patients upon request. Additionally, we now have some new initiatives in our outpatient pharmacies targeting certain drug classes and disease states. So they actually do also complete some targeted medication counseling for injectable diabetes medications, inhalers, and anticoagulants. Also in the ambulatory care environment and with our clinic-based pharmacists, like myself and Donna, we are now doing medication counseling for a new or change in therapy when we are actually seeing patients ourselves in clinic or when we're seeing them with other providers. We also do polypharmacy consultations for med education and optimization as well in this setting. In our inpatient setting, it is variable, and that depends upon the clinical service line. A lot of times medication histories are being taken place by pharmacists, as well as a lot of times high-risk medications are also being counseled on by pharmacists to the patient. A few examples of this include with our transplant team, the abdominal transplant service, they actually get multiple education sessions conducted by a pharmacist, and each of those is about 30 minutes to 60 minutes apiece. As well as with our specialty pharmacy, colleagues also provide additional education sessions at discharge. With our hematology service, they do provide extensive anticoagulation counseling with institution-approved handouts, which is also key to make sure that we're sending a consistent message during this counseling session. For documentation, this is also varies across the settings. For ambulatory and outpatient pharmacies, currently as of December 2016, we're doing paper documentation tracking forms for anticoagulation counseling. In our ambulatory care environment, we are doing chart note documentation that's visible in our electronic medical record. For the inpatient setting, again, it's also variable. We have IVENT documentation in the EMR. Some of our pharmacy colleagues also do chart note documentation in the EMR, as well as we utilize the education flow sheet that's available in Epic that's also used by other disciplines in the health system. With all of this that's going on for medication education, that's our current state, but what would be the ideal state that we would like to see? One thought would be that we want to have every single patient receive a medication history by a pharmacy team member when they get here into the hospital for hospital admission. Also have a patient receive medication counseling education upon discharge. Likewise, we also want to have another time when they get the education session when they're obtaining their medication from our outpatient pharmacy. And last but not least, another potential ideal state of medication counseling would be a follow-up encounter with a pharmacy staff member by phone or by face-to-face with a pharmacist upon return to their setting in the community for additional education and follow-up. Also, not only with the education delivered itself, we also want to ensure there's an ideal state of medication counseling documentation. So we would like to have an efficient and standardized method of documentation among all pharmacy team members. For example, all of us using certain standardized note templates or certain IVent templates so we can all have a consistent message when we're documenting the EMR. We also would like for that documentation to be visible to the care team and the provider in the EMR so they know what's been already taken place and so we can ensure that the patient receives the care. Last but not least, with this documentation, we would like for it to be in a format that would allow for capturing of data elements so we can actually show outcomes of what we're doing and how proactive we're being with providing this medication counseling. I now have a few examples of medication counseling documentation that we are currently utilizing here at UVA. The first one is that you may notice in our Epic in EMR system that we have an education tab. This is used by multiple disciplines, and in this tab, it actually allows you to document what education is provided to patients for a variety of different disease states. One that we use a lot is actually the anticoagulation education flow sheet, where we can actually document what anticoagulant they're being counseled on, who the learner is, what method we used, how did the patient receive this, and then also what kind of response did the patient state? Did they understand what we were telling them? Another example that we also are using for medication counseling documentation is that with our ambulatory care clinical pharmacists, we actually have an outcomes tracker that we use in our Visit Navigator that's currently in play that we're currently using, that was just developed recently. With this, we were actually able to document what kind of encounters we were having with patients, as well as what kind of education is being delivered to the patient, and so that we can use this information to know and track the outcomes that I mentioned earlier that are so vital for us to know the productivity and what we're doing as a clinical pharmacy team. I mentioned earlier a little bit about standard encounter language. One thing to think about in order to deliver consistent messages across the board as we have multiple staff members is to sometimes think about developing a standard encounter language. This is an example from a wellness pilot program that our pharmacy team was involved in. And what we did essentially is we kind of had the standard kind of language template to help provide guidance to pharmacists, and know the pharmacists don't have to say it word by word, but it at least allowed pharmacists to kind of give a consistent message when they're doing some standard counseling with these patients and getting information for med reconciliation. Donna alluded to this quite a bit earlier with our limited English proficiency patients. I actually take care of a lot of those patients in the clinic setting that I work in. One thing to make sure of is that you need to always be aware of what language assistance resources are available to UVA patients. So currently in our current state, we do have in-house Spanish interpreters that are available at various times during the week. We also have in-house American Sign Language interpreters. We also contract with agency interpreters in the area that can provide kind of on-site, face-to-face, personal interpretation for about 24 languages at this current time. However, if you don't have a live interpreter available, that doesn't mean you don't have access to an interpreter. We also contract with Seracom for an over-the-phone telephonic-based interpreting services. So you can access this telephone-based interpreter service 24 hours a day, 7 days a week, and it has over 150 languages, some languages that are very hard to find. You can also use this for Spanish. So I mentioned earlier we have a lot more in-person and in-house Spanish interpreters. You can also use this Seracom interpreter for Spanish patients as well too. It's very important that when you are using an interpreter for limited English proficient patients, you want to document who is providing these services in the EMR system, just so we can keep track of that we are actually providing the service to the patient. And you can do that in your note template, and also in some of the Visit Navigators in certain encounters, you can actually document directly in there too. One thing that I will note is that for some patients, you know, that they may believe they're English proficient, but you want to make sure that providers and staff that we have employed here are proficient in that language. So they actually can undergo testing if you have a provider that is bilingual or speaks multiple languages to ensure they are proficient, that they can provide medical care using that, using their own language and their own proficiency instead of having to use an interpreter. We also have assistance for patients that are hearing impaired or vision impaired, as well as, you know, we have the relay service in the state of Virginia to provide for our deaf and hard of hearing patients as well. This is what the kind of the blue phones look like that you may hear them referred to. We have cordless phones. There are also corded phones as well too. However, we also do have video monitors that you can actually do video interpretation with. That I would highly recommend if you've never used one. It's a very efficient method, and patients tend to like it because it's a more personal touch. However, even using the blue phone can be another effective method in order to provide interpretation, and it's very important that we do this. In order to get access, we have these cards that are available in the health system. You can get these from Language Services. This actually goes through all the prompts, and it's a stepwise approach, but it shows you exactly how you can get in touch with an interpreter if you're not even using a blue phone. So if you're on your regular phone or your work phone, you can actually call this number and actually get an interpreter over the phone using our access code for UVA. Another resource that UVA currently has is that we do have some calling cards, or what we consider calling cards, for our Spanish-speaking patients. So they can actually receive this almost like a business card where it actually has an access code. So they can actually call this telephone number with an access code, and they will automatically be given to a Spanish interpreter and get one on the phone. This only currently is available in Spanish language. The health system is possibly exploring other languages at this time, but right now this is only for your Spanish-speaking patients. However, when you do have patients that need to contact us that are limited English proficient, I tend to recommend that you give them kind of a standard script to go with. So when they call the clinic or call the operator, let them know what their name is. Also let them know if they can memorize their medical record number. That can be helpful. And if they can't do that, they can always just say their language, and our clerical staff can typically get an interpreter on the phone, and then they can obtain that information from the patient if they can't provide that automatically. With all this talk about interpreters, a lot of times many people think that once you get an interpreter on the phone, they just say exactly what you say. That's not always the case, however. It's really important, depending on what language services you use and what interpreter services, they have a very wide-ranging amount of training that they undergo. So when you use an interpreter for a limited English proficient patient, it's very important that you still listen. And I say that because I've had many experiences, and also in the pharmacy when we're doing counseling, it's a very complex session that you're providing. So you want to make sure that you're still listening to the interpreter to ensure that they actually are interpreting correctly in a sense. I have a study here that was conducted and published earlier this year in 2016 that actually looked at videotapes among medication consultations at a college of pharmacy in the Midwest. And when they utilized standard patients in this interaction, and they actually video recorded the consultations and then went back and analyzed the data. I've got some examples here of the results here. So on the slide here, you can see that for medication names, about 30% of the time, the medication name was actually omitted by the interpreter. Another important thing to note here is that for time to take medication, such as taking it with breakfast or take it with your evening meal, this was omitted also a very large number of times, sometimes anywhere from 40% even up to 60% at times. So it's important to know that even though that you're using an interpreter, you can't just zone out and not listen to what's being said, because typically you can still pick up on medication names and other things and actually ensure and use that teach-back method to ensure the patient understands how to take the medications. We're not going to be showing a video just to kind of refresh and show you another kind of example of the teach-back method. So we'll now be playing this video for you to get an example. And this video was produced here by our at University of Virginia Health System to help show this and educate our staff members on this.
Okay, Robin, so we're putting you on a statin for your high cholesterol, which is genetic and inherited. I do have a handout right here. This handout will tell you a little bit more about this medication. It is going to help an enzyme in your liver. It is important to remember not to drink any grapefruit juice while you're on this medication. Does that sound okay?
Yeah?
Okay, do you have any questions for me?
No, I don't have any questions. Thank you.
Great. Well, have a good rest of the day and see you next time.
I think she said to take this with grapefruit juice.
Okay, Robin, I'd like to start you on a new medication. This is called a statin for your high cholesterol. Another word for high cholesterol is hypercholesterolemia. So cholesterol is essentially a fat in your body, but you're maintaining a great diet, you're exercising as you should, which is great. With this new medication, there is a handout that I'm giving you. This will give you more information about this medication. It is important to take this medication once a day, so there's going to be one pill that you're going to be taking once a day at the same time, every single day. So I'll give this to you right now. Just take a glance at it and let me know if you think you're going to be able to read it just fine.
Actually, I need my reading glasses. My eyes are not what they used to be.
That's completely understandable. Not a problem at all. I'll just take this form from you and we'll get a larger print version for you. Oh, and also, I wanted to ask, do you drink grapefruit juice?
Not usually. Sometimes with brunch.
Okay, so with this medication, it's going to be very important not to drink grapefruit juice. And the reason for that is that grapefruit juice can change the way this medication works in your body, and we don't want any negative reactions or anything like that. So while you're on this medication, you'll need to hold off on the grapefruit juice.
Can I take this medicine with my other medicine?
You sure can. So I've just reviewed your medication list and there are no interactions, so you are perfectly okay taking this medication along with your other medications right now. And do you usually use a pill box at home? How do you organize yourself?
That would be great.
Okay, well I happen to have one close by, so I'll go ahead and give that to you.
Thank you so much.
You're very welcome. Can you tell me exactly what you're going to do when you go home with this new medication?
Yes, I'm going to take one pill every day at the same time.
Okay, anything else you can remember?
Oh, and I'm not going to drink any grapefruit juice.
Perfect. And remind me why that is?
Because they can change the way the medicine works in my body.
Perfect. You got it. And that's it. I'll just look forward to seeing you at your next appointment. They'll have the handout up front for you at the front desk when you check out. And they'll also be able to schedule your follow-up appointment in 1 month.
Thank
You're
you.
very welcome. Good to see you. Have a good day.
We're almost ready for our walk now.
All right. So now that we finished the video, we're now going to move to our assessment questions for this presentation today. So the first question, teachback includes. Teachback is a method, as an evidence base, is also called the show me method and is used to verify that a patient or family member understands what is being explained to them. If there is an understanding, the patient is able to teach back the information accurately. Is this true or false? That's right, it's true. All right, our next question. Barriers to learning communication include A, cognition, cultural ethics, language, motivation, sensory. B, cognition, culture, emotions, language, motivation, and sensory. C, cognition, culture, emotions, language, motivation, physical. D, cognition, culture, gender, language, motivation, and sensory. So the answer to this one is B. Cognition, culture, emotions, language, motivation, and sensory are all barriers to learning and communication. The next question we have today is the examples of sensory barriers include vision impairment, fatigue, aphasia, A and C, or all of the above. That's right, D, A and C. So visual impairment and aphasia are two examples of sensory barriers that patients may have. Where do you find materials for teaching and for other clinical communication needs? Micromedics Care Notes, Patient Education Repository, this link, which is to the Patient Education Repository, and the Patient and Family Library, which is located in the main lobby of the health system. And all these education and teaching materials can be found, or what we'll use clinically in the clinical environment to actually provide education to our patients. Last question. It is important to document patient education and counseling so that it can be tracked and viewed by other members of the healthcare team, and follow-up education can be formed if necessary. True or false? True. All right, here are the references for our presentation for me and Donna, and we will now take any questions.